So we have a wonderful expert panel who are to present and discuss this topic. And it's 5 professors, and I think a conservative estimate is to say that they have taken together at least 100 years of serious thinking and research in this area. And it's Michael Hunt from Vancouver. It's Lynn Snyder-Mackler from Delaware. And Michael will start presenting, followed by Lynn. They will give 2 10-minute presentations. Thereafter, we'll hear some opinions from patients, and they will be questioned by Professor Steve Messier, and these patients have been involved in one of his studies. And finally, there will be a discussion where all the panel will be asked to contribute to respond to different questions. And in addition to Professor Hunt, Snyder-Mackler, and Messier, we also have Neil Segal from the US and Professor Arna Risberg from Norway. So the panel is from 3 different countries, and they span, I would say, the age that we see in people with osteoarthritis as well. And there may be some people who have a prior knee injury and who now have developed osteoarthritis. I don't know. We'll maybe hear more about that. So, and there will also be time for some questions from the audience in the end. So I would like to welcome Professor Michael Hunt to give the first presentation. Michael, the floor is yours.
Thanks very much, Eva, and thanks to you and David for the opportunity. It's a real pleasure to provide some insight today. I'm just going to share my screen. Okay. So I have no financial relationships or anything to disclose. So the question is, does strong muscle matter in OA? And I think the resounding answer is yes. I will put a little bit of an asterisk there, and the last 5 minutes or so of my talk, I'm going to look at maybe some other aspects of muscle function in addition to strength that might also be important. And some of the data that I'll be presenting today obviously will also try to figure out where we actually are in terms of our knowledge in terms of strength. So how are muscles important to OA? So there's a number of ways that muscles are important. One is it provides an enhanced chondrogenic. So there's lots of evidence out there to suggest that strong muscles can promote the formation and production of collagen. There's also some metabolic benefits as well. And Dr. Messier is a real leader in this field in terms of looking at what muscle and exercise in particular can do to the metabolic environment relevant to OA. There's also been some research showing that strong muscles are important in the regulation of certain inflammatory pathways, so interleukin-1 beta or TNF-alpha, and as an opportunity to really slow down the progression of OA, or in some cases even to develop it. Strong muscle, of course, provides a means to be functional. I think that's one of the key points that will come out in the talks and the discussion today, is that there's a real strong and known relationship between muscle function and muscle strength and our ability to have good physical function with or without the presence of OA. Strong muscle can theoretically provide stability to an unstable joint, and I'll provide a slide later on to talk about what might happen in situations where we do have an unstable joint, and I'm sure that Dr. Snyder-Mackler will also be talking about instability as well. And finally, it provides an ability to absorb load, and this is really important when we're talking about functional activities and certainly activities that promote moderate to high impact loading. So, I mean, of course, in 10 minutes, I can't cover everything, and given a real almost impossible task to cover that. So this is a nice review paper. I would suggest people look at it. For 2018, just showing the 3 different areas of how skeletal muscle is relevant to OA. What I'm going to be focusing on is the muscle strength and the muscle activation side. And the strategy that I've taken, again, I've only got 10 minutes or so, is to really look at papers that are either systematic reviews or meta-analyses, or that have used very large cohorts. And the other strategy I've used is to try to find papers that have been published by the panelists, so that they can provide insight into that. And given, as Eva mentioned, given that the other panelists are true leaders in the field, that wasn't an overly difficult task. So we all know, and Eva alluded to it, that exercise, especially those types of exercise that include muscle strengthening, is a core treatment approach for all people with OA. And any clinical guideline that you look at will show that exercise is fundamental across the spectrum. And so this was a study that just came out last year. It's a really interesting, neat little study, really asking the question of, do we need more data, do we need more research to prove that exercise and muscle strengthening is important? And so what they did was they did a series of, in essence, meta-analyses and systematic reviews going all the way back to 1992, looked at 42 studies. And basically what they did was, in the year 1992, what do we know? And what's the effect of exercise on, in this case, pain? And so on the x-axis, what you'll see is the effect size. And so we all know that the higher the effect size, the better the effect, the better the benefit. And then they jumped forward to 1996 and said, okay, there's been some studies that have been published in the meantime, and all the way up to 2016. So they were adding studies as they went along through time. And what you can see here is that the dots which show the point estimate of the effect is relatively stable. And so the point they were trying to make there is that exercise is important, exercise is beneficial, and we've known it for a long time. So I think what we're trying to get at was why is exercise not more common and not more widely supported? There's strong evidence linking reduced muscle function, and I'm specifically using the word muscle function rather than strength, because we're going to be talking about different measures of muscle function. And metrics of OA development progression. And what we'll see is that this effect might be more prevalent in females than males. So the first study, and again, we're trying to look at large studies, systematic reviews, meta-analyses. This is a study that was published in 2015, and what they did was looked at all longitudinal cohort studies that had looked at knee extensor muscle weakness and the risk of developing knee OA. And so over the course of 2.5 to 14 years, what they showed was that the odds ratio for weak, and what I mean by that is when you compare those in the weakest tertile to those in the kind of the second tertile or the strongest tertile, there's a 65% greater odds of developing OA in that weak group. And it doesn't matter whether we define that as symptomatic OA or radiographic OA, it was a 65% greater odds. If we're simply looking at structural development, that's the X-ray, there's a 58% greater odds as well. So pretty clear evidence showing that weakness is a bad thing. A subsequent study came out a couple of years after that, again, looking at the knee extensor strength using data from the MOST studies, one of the two big cohort studies that are currently being done in the United States from an OA perspective. 904 individuals in a single study looked over the course of 7 years. In this case, looking at relative risk and comparing the strongest group, so those with the strongest muscles, compared to the other groups. So in this case, anything under 1 in terms of your relative risk is a good thing. And what they showed was that those who were in the strongest group were at a reduced risk of developing OA. What I will show here, though, is the asterisk shows that this was only statistically significant in females. As it pertains to structural OA development. A little bit, not much of a difference, but there was no statistical significance when you're looking at males. In terms of progression, again, using data from the Osteoarthritis Initiative, which is the other large longitudinal cohort study, this was an interesting study where they took people and looked at the concurrent progression. So those who lost strength concurrently rather than just looking at baseline values, and the development, and the progression of OA. And again, what they found was over the course of 4 years, those who had a concurrent loss of strength, extension or flexion of the knee strength in females had a progression of symptomatic OA. And again, in females only, not in males. And then finally, a systematic review and meta-analysis looking at symptomatic and functional decline as well as structural. A large systematic review, more than 8,000 individuals over the course of 1.5 to 8 years. Again, this is a situation where we're comparing the weakest group compared to the middle and the stronger tertile. And again, a 35 or 38% increased odds of progression of pain and functional decline not so much in terms of structural progression. So I think the take home from those studies are that weak thigh musculature, both flexors and extensors, is a risk factor for structural and symptomatic knee OA development. Conversely, strong thigh musculature may be protective against structural development, maybe less so in terms of symptomatic development. Again, along the same lines, weak thigh musculature is a risk factor for symptomatic progression, maybe less so for radiographic progression. And then in terms of being strong, or the strongest group, that effect might be less so. We know that it's more relevant in females than it might be in males, and I'm interested to hear what the panel thinks about that. And I would argue that it's more relevant to the low strength group, the weakness group, than these findings are to the strong group. And that's part of the little asterisk that I had at the start of the talk. So what I just wanted to touch on in the last 4 minutes or so of my talk is what are some of the limitations of examining muscle strength? So muscle strength is a measure of maximum muscle capacity. So how much strength or how much force can you produce for a given movement? Unfortunately, very rarely do patients with knee OA, or anyone, quite frankly, other than maybe strength athletes or professional athletes, very rarely do people with knee OA perform a maximal exertion task. And so this is a study that literally just came out this past month. And for those of you who are aware of surface electromyography and from a biomechanics perspective, they were looking at what percentage of overall muscle activation, young and older, so in the old group, we're looking at about 70 to 75 years on average, what percentage of maximum muscle activation do people use during certain activities? And what you can see here is during walking or stair descent or stair ascent, the old group, which is the gray bars, the most they ever used in these activities was during stair ascent, and it was only 20% of their overall muscle activation. So again, proving that we rarely use all of our maximum capacity. Muscle strength is generally a more static or long latency measure. And what I mean by that is when we generally measure strength, it's in an isometric situation. And there's no real emphasis on getting it done as quickly as possible. It's get to the point where you can produce as much force, hold it there, let's see how much force you can produce. However, in many instances, we know that fast responses are needed. So think about recovering from a trip or a fall, which has implications in terms of falls risk. And we know that people with knee OA are at a significantly increased risk of falling. And think about something like a varus thrust. And we know that varus thrust, which is a very short duration, high velocity lateral displacement of the knee joint during the loading phase of walking. There have been a number of studies that have shown that the presence of a varus thrust is a risk factor for both development and progression of knee OA, whether you look at structural progression or, in the case of Dr. Felson's work, looking at things like bone marrow lesions. So the question is then, what about power? So power is the ability to produce force and the ability to exert strength in as fast amount of time as possible. So this was a study that came out last year, and they were looking at what factors are related to gait characteristics in people following a total knee arthroplasty. And really what they were looking at is what we call the knee flexion excursion, or the amount of flexion that we get during the loading phase of gait. And we know that that is indicative of a smooth and efficient gait, the ability to absorb loading during that high impact period of the gait cycle. And so what they found was that the rate of quads torque development or quads force development was the greatest predictor of how much flexion excursion someone had during gait following TKA. When they put all of the variables into their regression equation, either at 3 months or at 6 months, again, quadriceps rate of torque development was the number one variable that was predictive. When you look at that peak torque, or the maximum amount of strength, that was not statistically significant. So again, showing that maybe the power might play an important role as well. A study that came out in the Journal of Physical Therapy a few years ago, what they were looking at was what measures of muscle function relate to physical function outcomes. And so they were looking at the 6-minute walk test, they were looking at the timed stair climb task, or a timed stair descent task. using a number of different covariates. And really they were looking to see whether strength or power would provide most of the explained variance. And in all functional outcomes, 6-minute walk and the 2 time stair climb tasks, the R squared value when you use power rather than strength was higher. So 39% versus 33%, 60 versus 54. So again, about a 6% more explained variance when you use power rather than absolute maximum strength. In terms of a clinical situation, not everyone necessarily has access to an isokinetic dynamometer. And things like simple things like a single hop test, which we know is a very good indicator of lower limb muscle power. There have been a couple studies in the past year from Dr. Roos and Dr. Snyder-Mackler's labs that have shown that a single leg hop tests are important, and they do have a lot of clinical relevance. So they can be used to examine patient-reported outcomes in patients who have undergone degenerative meniscal tears. And what they showed was that over the course of a 2-year follow-up, those who performed better on the 6-meter timed hop test at baseline had better patient-reported outcomes at the 2-year follow-up. And from Dr. Snyder-Mackler's lab, showing that those who performed better on a single leg hop test were at a reduced risk of developing post-traumatic OA 5 years after an ACL injury. And I'm sure she's going to be talking about that in her presentation next. So that's in terms of overall function. The last 2 slides that I have are to look more at muscle activation. So not necessarily how much you can activate your muscles, but how you activate. What's the quality of the muscle activation? And so a study a few years ago came out of Australia showing that when you look at the amount of co-contraction, which we think is an inefficient muscle activation pattern, those who had increased duration of medial musculature co-contractions of the vastus medialis and semimembranosus was associated with cartilage loss over 12 months. You can think of that as structural progression. So higher amounts of co-contraction, less effective, less efficient muscle activation patterns could potentially be problematic. Conversely, if they look at the lateral side, vastus lateralis and biceps femoris, co-contraction was actually inversely associated. So they found that might have been protective. And then finally, out of the group at Dalhousie in Halifax, Canada, looking at longitudinal outcomes, comparing baseline characteristics, gait characteristics, and biomechanics in people who progressed to a clinical outcome, in this case, progressing to total knee arthroplasty. What they found was, and these are the EMG curves during gait in the lateral hamstrings on the left and the rectus femoris on the right. The blue solid line is those who progressed to a TKA. The dotted lines is those who didn't progress. And what you can see is during kind of that loading phase of gait, people who progressed, ultimately progressed, exhibited longer duration and higher amounts of muscle activation during loading phase in both of those muscles. So again, it shows that it might not necessarily be simply the amount of muscle that you have or the quantity of muscle. The quality of the muscle function is certainly important. So final take homes, and again, just 10 minutes, so we tried to cover a lot here in 10 minutes. To answer the question, absolutely muscles are critical for knee OA. I don't think there's any question about that. Certainly as it pertains to functional ability as well as protection of the joint. But from a researcher and a clinical perspective, know your comparators, know your outcomes, know your priorities. Is it weak versus strong? Is it old versus young? In terms of outcomes, what are we looking at symptomatic progression? Are we looking at structural progression? And what are your priorities? A cure for OA doesn't exist. So are we interested in changing biomechanics? Are we interested in changing pain? What are your priorities for a particular intervention? So I think the key point from where I want to come here is you don't necessarily need to be Superman, but don't be weak. And so again, that goes back to those studies where those in the lowest tertile tended to do worse than those in the highest tertile. And so from a clinical perspective, I would argue, don't just focus on pure brute strength, consider muscle quality. And I always advocate for, neuromuscular retraining to change those muscle activation patterns to complement the traditional strength training. And with that, I'll leave it there.
Thank you so much, Michael. That was a really good start. And now we will have an even better continuation. Lynn?
That's very nice of you, Ewa. Hold on.
Yes.
Here we go. Okay, so I'm going to talk about, post-traumatic osteoarthritis. strength training for post-traumatic osteoarthritis. So something that Ewa basically brought up, we're talking about, sorry, this is advancing itself. Young people with old knees is really where we are. So PTOA is a progressive disease. Osteoarthritis starts here with a knee injury. Here, this is a meniscus. And causes these impairments or these resultant impairments, muscle weakness, loss of range of motion, and movement disability. Generally, they can't, difficulty getting around, which leads to progressive OA, as Michael just talked about. These are risk factors and feeds back in. Now, this isn't immutable because all these impairments we can affect with exercise or rehabilitation. Knee OA risk is increased 4 to 6-fold after a knee injury, and this may even be an underestimation. When we look at this, we always talk about people being overweight or obese and that being a big risk factor. Look at this. The red line, any of these studies where the black diamond is to the right, it shows you that these studies, this whole collective group of studies, shows that this is a risk factor for knee OA. Previous knee injury is, if you look at the numbers at the bottom, around 3 with that big collective black diamond, where overweight and obese, which we talk about all the time, is 2. Okay, with all of these collective studies. So previous knee injury is really the biggest player. And in fact, it affects these people when they're very young. They get OA in their 30s. Quadriceps weakness is ubiquitous after intra-articular knee injury. Each 13 Newton meter increase in strength is associated with a 20% reduction in the odds of radiographic knee OA and a 30% reduction in the odds of symptomatic knee OA. Quads are in fact the magic muscle. Increasing their strength by only to 20 to 25% predicts a 20 to 30% decrease in the odds of having knee OA. So is strength training exercise good OA medicine? Here's a group of systematic reviews, meta-analyses, and clinical practice guidelines from 2010 to 2019, including the ACR Arthritis Foundation recommendations from 2019 and the ORSI recommendations. And if you look at the conclusions on the right-hand side, what you see are exercises recommended, exercises strongly recommended, exercises recommended with a high consensus. Oops, there we go. The OMEX study, which 2-year results were just talked about a little bit by Michael. This is Dr. Risberg and Dr. Roos's study with their graduate student using a set of exercises here on the side that if you actually go to this paper, this particular paper, the appendix has all the exercises and the progression available for anybody to look at, including our patients and colleagues who are on this call. This group of exercises, this progressive exercise, compared to the most common surgical treatment for degenerative meniscal tear, which is arthroscopic partial meniscectomy. As you can see, the blue on just the peak torque knee extension, the strength of the muscles, and then the KOOS, which is patient self-report, the blue is much higher than the red, and that persisted out to 2 years. What about, does the intensity of the exercise matter, or can, people can't just start out doing high intensity exercise. So what about exercises that are carried out at less than 70% of their 1 repetition maximum? Here again, we have the same set of plots where you're looking at for these green squares or the big black diamonds to be to the right of that black line. And in fact, low intensity exercise is effective, but high intensity exercise is more effective. And here you see that those black diamonds being way more to the right, and then not only for knee extension muscle strength, but also for knee flexion. So is strength training exercise a good and efficient treatment for OA? Yes. My colleague Joe Zenny and I have shown that stronger quads benefit arthritic knees and slow progression of knee OA. And in this study, it actually showed that it may slow the progression of hip OA as well. One of our graduate students here at the University of Delaware, sort of academic grandchild of Dr. Felsen, has just shown that too little physical activity, actually, people are worried about worsening their OA if they're physically active, which is part of this whole strength part. She's actually shown that too little physical activity may actually lead to OA. So underloading as well as overloading is bad. And my colleague and Dr. Felsen's former postdoc, Dan White, has shown that people who walk forget 10,000 steps for happy knees, 6,000 will do. So we for each 1,000 steps that patients added to their daily activity, reduce their risk of mobility loss by almost 20%. And Grace Lowe and her group, again, from these large epidemiological studies, has shown that in individuals over 50 with knee OA, running is associated with less knee pain. So don't be afraid of this physical activity. And Steve Messier, who's on this call, and Dan White have shown, Steve through experimental data and Dan looking at large epidemiological work, has shown that intensive diet and exercise programs prevent knee pain among overweight adults at high risk for knee OA. Eva, her work with the GLAD study with really large numbers of patients, the bottom line is if your knee hurts, keep exercising. And how much pain relief one gets depends on how much exercise one does. In Eva's study of 10,000 people with knee and hip OA, she found that people who exercised twice a week for 6 weeks experienced overall 25% pain relief. While most people experience a slight increase in pain when they start to exercise, those of you on the call who are patients need to understand this is not a warning sign, but the body's signal that they're doing something they're not used to. Our bone and muscle and cartilage are great at adapting, and their quality improves when we exercise. So Eva's 2 rules here for joint arthritis pain, we're not talking about muscle pain here, but your knee pain, your irregular arthritis pain. You can exercise safely by following these 2 simple rules. 1, the pain you experience after exercise should be at a level that's tolerable, and 2, you shouldn't experience any increase in pain from day to day. The pain should be assessed daily after exercise on a 0 to 10 scale. On this scale, 0 to 2 is safe, 2 to 5 acceptable, and 5 to 10 avoid. Now I want to reiterate, muscle soreness is not only okay, it's desirable. You know your muscles are getting stronger when you have this delayed onset muscle soreness. So we're not talking about muscle soreness here. So the big 3 impairments are quad weakness, knee range of motion, especially knee extension, and walking impairment. All of these are modifiable with rehab. So let me just step into just slightly into my colleagues who say, I'm scheduling your total knee for October or November or December or 18 months from now in some countries with long waiting lists. So what do we do with these people in the interim? We do this basically the exercises from the OACS study, lots of strengthening exercises, progressive strengthening exercises, and we can, in fact, decrease TKA utilization. Dan Riddle, in a study here in the US, reported that nearly 35% of TKAs in this well-documented sample were inappropriate. This is a picture of my husband doing his exercises from the OACS study prior to his total knee, where he increased his strength doing this by about 20% at all of his physical function tests. This is a very recent infographic from Eva and Jackie Whitaker about all of these factors that contribute to post-traumatic knee OA. And the 3 that are in the red circles are if you exercise less and stop sports, if you have muscle deficiency, if you have inadequate or delayed exercise therapy, those all contribute. This is all saying, get out there and exercise and do, if possible, high intensity strength exercise. We at the University of Delaware do this UD OA profile testing that includes isokinetic muscle strength on the right, 6-minute walk, all of the OACS recommended physical function tests, as well as obviously range of motion. And we also look at hip muscle strength using a handheld dynamometer. We also have a very large normative database, age-matched individuals without knee OA, and when we send the report to their physicians, we send this along with them. We're looking as people have OA to make sure that we want them to be going up, not going down in all of these tests. Now, there's a lot of cool tech out there right now, and there's a lot of buzz about the use of, about the use of technology like fitness trackers to get people to do more. I'm more interested in using this tech to get patients to us and us to them. The future is now in the use of these hybrid technologies where a PT designs and advances the program remotely and gets feedback from the patient or the trackers or other tech. So take-home messages are address quad weakness, which is an important risk factor for hip and knee OA. Use all types of muscle strength exercises, both weight-bearing and non-weight bearing. Exercises must be progressed. That means more weight, right? More reps. Research strongly supports strengthening and weight-bearing exercises for patients with knee OA, even those in end stage. Rehab needs to be tailored and monitored. High resistance muscle strength training is more effective than low resistance, but low resistance works, and it needs to be tailored and progressed. Technology is part of the answer to implementation and monitoring. This is a BJSM infographic that I think is a really important thing to get across to patients, that the belief that therapeutic exercise may harm the knee joint cartilage is still common among people with knee OA. Therapeutic exercise relieves pain and does not harm cartilage or trigger inflammation. It's safe and effective. You need to exercise. Thanks. Can I stop sharing?
Well, thank you so much, Lynn.
Let me stop sharing. Or
we've had two great presentations here, and I think we can actually clap a little bit for Michael and Lynn. Very well done. Thank you so much.
Thank you.
But now comes the important aspect. Do the patients agree? You seem to agree that people should exercise and they should do strength training. They don't need to be Superman, but they should not be weak. But what are the patients' opinions? So I will leave the screen to Dr. Messier, who has brought two of his patients, and we'll ask them some questions about their opinions and what they think about this with strength training and exercise. Steve?
Well, thank you, Eva. I'd like to introduce Jim Scott and Ray Norris. And Jim and Ray were participants in our strength training and arthritis trial, or START. And just a little bit about that trial. It included 377 older adults with knee osteoarthritis. Jim was in the high-intensity strength training group, and Ray was in the low-intensity strength training group. And there was also a control group. The interventions were 18 months in duration. We presented these results at the last ACR meeting, and the manuscript is currently under review. Jim and Ray, are you there?
Yes.
First, could you just tell us a little bit what is low intensity and what is high intensity strength training? Just give us some kind of indication of what it is.
Sure. The high intensity strength, we had a 9-week series. They did 2 weeks at 75% of their 1 repetition maximum. And then they did 2 weeks at 80, 2 weeks at 85, and 2 weeks at 90. And then the last week was kind of a rest week. We got a new 1 RM for them, and then they just repeated the whole thing. So it was a progressive thing. The low intensity was between 25 and 35% of their 1 repetition maximum, with the same 2. Of course, the low intensity had a greater number of repetitions compared to the high intensity. So the total volume of work that they did was equated at the beginning of the study. So everyone did the same volume of work to begin with. So those were and this went on for 18 months. So Jim and Ray, just a couple of questions for you. One is, and we'll start with Jim. Are muscles important to you, Jim?
Absolutely. Very, very emphatic yes. Just from day-to-day functionality and balance and daily activity as far as overall mobility and functionality is concerned.
Great. And how about you, Ray?
Well, I just have to echo what Jim said. I think it does help me to be able to participate in daily activities. And I know from a time when I wasn't exercising that I began to see some of these things happening. You referred to like balance and things, but that has been better since being in the program.
Yeah, so Ray, tell me a little bit about how your muscle function and how the study has impacted your activities of daily living, your well-being, those kinds of things, and your pain.
Well, the pain side of it is something that comes and goes, but like the people talked about in the studies about that they encourage their participants is to keep at it. My wife and I lived near Parris Island, the famous U.S. Marine training base, for a long time, and they have a saying there at the recruit training: pain is the sign of weakness leaving the body. So maybe some of your researchers would like to put that on the wall. But that's one of the things too that before I was in the program, I did have that fear that one of the researchers talked about pain and worrying about doing damage to the menisci. And I really appreciate getting the reinforcement today from the reports that's not really a factor. And the thing is, once we're able to get back after this quarantine business is over, I want to work on the progressive aspect in the follow-up program that I'm in. That's something that Dr. Messier didn't mention, but one of the really nice things that Wake Forest University does is they have a program called HELPS. And if you've been in a research study, you have the opportunity to enroll in that. And it's also people who haven't been in research studies, but I think that's really another important factor. If you can offer people the opportunity once a study is over to have that kind of opportunity to work on their own. And that's the other thing that it gave me, was the opportunity to have a protocol to follow. And with the quarantine now, and I've been at home, I've been using exercise bands, and I've got a stationary bike. And so I've been able to do that. It's a little hard to talk about activities of daily living because it's mainly just right around the house. But I did notice that when weather improved and I was able to get back in the yard, I did have a few aches and pains for a few days, but not long. I accommodated to using muscles in a different way. I think I wouldn't be doing yard work now at all if I hadn't been in the START program, in the follow-up program, the HELPS program.
Right. How about you, Jim?
Yeah, actually, one of the things that was very, very noticeable was a very significant reduction in pain and discomfort with the increased exercise. And I guess, in all honesty, as far as this quarantine situation is concerned, I have not had access to facilities and resources, and I've noticed a loss of knee strength, and I can definitely feel it. So I'm, other than walking at least 4 to 5 times a week, not able to do the kinds of strength training that we did with the machines. And I definitely noticing how much I miss that. As far as other benefits, though, as I went through the START program and continued with the HELPS program that Ray mentioned, just an increase in range of mobility, range of motion, and improvement in overall balance. And those are benefits that looking forward to recovering those as I get access to resources again. So
you trust your knees a little bit more then, it sounds like, Jim.
Oh, absolutely. Yeah, the difference is very, very noticeable. And I guess, again, from the standpoint of just even balance, I'm never concerned about falling or anything like that. Like I know many other people that are dealing with knee arthritis have some real issues with that. So again, the benefits of the exercise are really immeasurable from my perspective.
Ewa, one of the interesting things about the START program, most of our programs, as you know, are exercise and weight loss. This was just strength training. And usually the ratio of participants is 70 to 30 female to male. For this study, we were really surprised it was 50-50. We had a lot of guys that wanted to do it because of the strength training. And one of the things we did is we did both upper body and lower body, because even though we're concerned about the knee, everyone wants to look good overall. And so we always incorporated some upper body as well as core and with a predominance of lower body exercises. Any last words, Ray? I'm afraid to ask you, Ray, last words,
No, I don't have anything else to add.
Okay.
So could I take the opportunity to ask Jim and Ray a last question?
Sure.
So who of you were randomized to the Superman group?
We would call it Superman group, high intensity group.
High intensity group. That Jim was the Superman group, and I've got to tell you, that fits him. He's the most impressive participant that I saw in the whole program. I tell everybody I was a very pedestrian kind of participant, but he was in the Superman category. And one of the things I hated with the Nautilus machines was to come immediately behind Jim, because I'd be setting the pin about a third of the way down and he'd be maxed out at the bottom. And I even joked, I said, Jim, I'm going to have to start standing on your shoulders to add more weight so you can max out further.
Well, I
But
don't
you
think that's
both
what we deserved.
feel the pain relief and you feel functional improvement, that you can do more, you have better balance, you trust your knees more.
Oh, absolutely. Absolutely. Without question.
And that goes for you too, Raymond?
Yeah, I've had, arthritic knees probably for about 20 years now. And I've gotten very used to, whenever I exercise, I'll always wear just elastic knee braces. The thing is, I don't think I trust mine as much as Jim does, but like I said, Jim again is in a different category from where I am. But a few times I've been out walking or something, I've forgotten my knee braces and everything's been fine. So
thank you so much. Thank you so much for joining us and sharing your perspectives.
You're welcome.
And you're welcome, of course, to listen to the discussion now with the panel. And at the end, there will be questions from the audience as well. And then you can ask questions if you would like as well, of course.
Thank you.
So, panel members, are you there? So now we have the opportunity, or I have the wonderful opportunity to ask the panel to share their thoughts. And I think what we've heard here is that what Dr. Messier has done is that he's actually done a study, if we start there, where he compared people who did the Superman training, the high intensity training, with the more activities of daily living training. And that actually seems to equal what Dr. Hunt shared with us when he said that most patients never use more than 20% of their one repetition of maximum. So that seems to be more like the low intensity group in Dr. Messier's trial. And as far as I see, there is really no difference in the improvement between these two groups. So the first question that I would like to address to the panel is there a role for aggressive or high intensity strength training in treating people with knee osteoarthritis? And would you like to start, Dr. Messier?
Yeah, sure. Well, what I presented at ACR was a surprise, both to me and I think most of the people in the audience. And that is that we figured a priori hypothesis was that the high intensity group would do better than both the low intensity group and the control group. And indeed, both the high and low intensity groups significantly improved their strength relative to the control group, with the high intensity group being a little bit better than the low intensity group, but not statistically different. But they were both statistically better than the control group. But all three groups actually reduced pain, improved function, reduced IL-6 values. They all did, even the control group. And all three groups their improvements were clinically significant. That is, they all passed the Omerack-Orsi criteria for improvement in pain and function. And so, I hesitate to say too much more than that because it's under review still. It's not published yet. So take it for what it is. But everyone did well. Everyone did well. There was not, one interesting thing was the low intensity group actually reduced pain medication statistically more than the other groups, which was kind of a surprise. And they all reduced pain medication, but the low intensity group was statistically better.
So may I ask Dr. Hunt, are you surprised by these results?
Yes and no. I mean, I think what I was trying to get at earlier was that this whole notion of functional capacity versus functional need. And I don't know what the number is in terms of what the minimum or the required amount of muscle function is. But a lot of the work that, again, Dr. Messier has done great work, and others as well. Do people need to get to that minimum threshold, or do they need to exceed it? And I think really it comes down to two things. One is, how much does an individual person need? And the second part is, how much did they start with? And is it possible that those people who started out very, very low did need a high intensity intervention to get to that minimum threshold? And I think that comes back to another point that that many people, including yourself, Eva, have been making over the years, is that exercise works. There might not necessarily be one that works better than others. And I think it comes back to tailoring it to the individual needs of the patient. And so, of course, the important question there is, how do we identify what is best for the person that's sitting in front of us? But there certainly is no one-size-fits-all approach.
Dr. Snyder-Mackler would like to.
I have two things. One is, let's not generalize this all the way to PTOA and young people with a knee injury and what they have to do to be able, again, what kind of rehabilitation they should be doing. But also, Michael's, that particular paper that you brought up, realize that EMG activity is not percent muscle strength. So when we're talking about EMG activity, the amount of muscle strength that it takes to go foot over foot up and down stairs without significant superincumbent body movement is about 60%, which is pretty high for our OA population. It's not 20% of their muscle activity. So we need to really be able, you need to be able to think about EMG. It monotonically increases with muscle force, but it is not muscle force. So we need to be very careful about how we extrapolate that.
I think that's right, Lynn. I think we have idiopathic OA, which is what I deal with, and you've got PTOA, which is a totally different animal. So I think that's an excellent point on your part. Yeah.
Can I interrupt for just a minute with two things? One is I really hope that this session would be more about strengthening, a la Steve Messier's trial, and not so much about exercise, although there are questions in the chat room about exercise. I think that's not the primary focus here. Second, I will ask you, Steve, to comment a little more on your trial, which you presented nicely at the ACR. And I guess I wanted to ask you to comment on two things, and I wanted to provide a little background to my concerns about those two things. One is that Neil Segal, who hasn't said anything in the MOST study, has never found an association of muscle strength in men with any OA outcome, okay? And as Michael Hunt said earlier, this is a story about women mostly, okay? There are some exceptions to that rule, but not mostly. The Charlie Slamenda, Ken Brandt work from years ago, which was wonderful, found only women were affected by this issue and not men at all, okay? So, and we find the same in most. And I guess I wanted to, and then I would just comment that Martin England, who's also on the line, did a lovely study of Swedish Army inductees who had strength measured and found that higher strength men got more osteoarthritis later in life, okay, than men that weren't so strong. And what this suggests to me is that strength is sort of a bimodal issue, okay? That many older women are too weak to be able to stabilize their knees, to provide the other functions that muscle health provides. And many younger men, and perhaps even older men, are so strong compared to what those limbs need and our joints need, that they can create a vice-like effect on their knees that can cause damage, okay, and perhaps even pain. And that leads me then to the question to Steve, okay, because in listening to your ACR presentation, you had mostly men in that trial, okay, and while you said there were no differences between the groups, and I guess that's statistically true, Steve. I mean, the truth is that the aggressive strengthening group did a little worse than the lightly strengthening group. And I guess I want to pose that to you in the context of, can strength be bad? Okay, we know that strength, that conditioning is good and healthy if someone is really weak because it protects their joints. But is it possible that we can go too far, especially in people who really don't need strengthening?
Well, I'm sure everyone has an opinion on this. I'll start, I guess. First of all, both strength training groups did no harm to their knees. We looked at X-ray after 18 months, and there was no difference in the progression of the disease between the two strength training groups and the control group. Second thing is, all three groups, as I said, decreased pain medication, which is a good thing, right? It was about 50-50 males and females. There wasn't that much different. And David, after that meeting, during that meeting, during the question and answer period, you did ask, you hypothesized, well, maybe the people in the lower half of the strength did better. And so, of course, got off the airplane and went right back and looked at that, David. And the results were the same. The results were the same. So I guess I'll stop there and let others talk.
Thank you, Steve. So I would like to ask Arna Risberg, were you surprised when you heard these results that both groups improved with no difference between the groups? Can you please unmute yourself?
Well, not really, and not really because we heard those two patients talking. And if we are going to answer the questions related to your first question for this discussion, is there such a thing as optimal exercise program for people with OA? I would answer, for whom? And I think the two patients were really good in describing how the program really fitted them. So I don't think there is, as also been mentioned, there is no such thing as one size fits all. There is an optimal program for each individual patient that need to be tailored. And I also believe that there are lots of people who would respond very positively to also a low intensity program. But if I understood this paper that's not published yet by Stephen Messier and his group, right? Both of the groups really exercise within the same volume. Was that correct?
Yes, they all were equated at the beginning. Absolutely.
Yes. Mm-hmm. Yeah. So I don't think there is one factor. So a lot of people would respond negatively if you start out with high intensity exercises or strength training exercises, but these people will not continue to exercise because they get too much pain. And this is where it comes into the really, really important message that each patient has to be their own, in the end, their own therapist. They have to find out, how does my knee respond today, this week, to this program? and adjust the dose according to that. So I'm not surprised that with the same volume of exercising, the strength training exercises, that the low intensity group got the same results as the high intensity group. I haven't seen the study yet, I just heard it now. So I believe that this needs to be tailored to the individual patient. It has to also be tailored according to what the patients like best, what they prefer, and most of all, what is the patient's individual goals? Is it to climb a mountain, or is it to walk a couple of blocks because they need to get the groceries and up and down stairs? So I think we should stop putting this into a black and white colors, because it's not. It has to be tailored. It has to be optimal for each individual patient. And maybe we should do more pragmatic studies and let the patient decide what arm they should go into.
Lynn, you will get a short.
I'm just very uncomfortable discussing a study that we don't have all the information for.
Yeah.
There are lots of reasons. If
So am I.
are super, I know you are, Steve. If people are coming in at a very low strength, any stimulus is going to have an effect in that amount of time.
Yeah.
And they may in fact be equal, but may not stay equal. We'll see with long. So let's not throw the baby out with the bathwater here.
And Eva, you called it aggressive. I don't like the term aggressive. It's progressive. It has to be progression of the exercises. It's not aggressive.
Yeah.
And
I actually borrowed that word from David.
And one more thing for your patients, Steve, when they were talking about being at home, I know I pointed out the 3-month paper from Arna and Ewa and their graduate student in Journal of Orthopedics and Sports Physical Therapy about the 3-month results of the OACS study. There is an incredibly great appendix in that. A lot of those progressions can be done at home. And that would be something that I always recommend to my patients. It's a lot of body weight exercise that can be augmented. And that appendix is something that pretty much anybody can read and do, not necessarily with therapists. And it is freely available on the web.
Yeah, thanks, Lynn. We have a home based as well, but we'll definitely take a look at that.
So, Dr. Segal, you haven't got you haven't got a word here because.
Well, there are a lot of brilliant people on this call, so I've been taking it all in.
Talkative colleagues. So I would like to ask you about your experience before we leave this topic with progressive strength training or low intensity training. So what about adverse events and adherence to these different types of programs? Do you have anything that you would like to add when it comes to that?
Sure. Well, Dr. Messier has been impressively successful with these trials with high intensity or I should call it high load strength training. When I attempted to do that, I had a 3-arm study several years ago where we had a high load, a low load, and an educational program. And the patient, it was for idiopathic osteoarthritis and similar aged people. They couldn't tolerate it. We were having multiple adverse events, even though we had great strength trainers who were being very careful and ramping people up slowly. It just wasn't tolerated, and we needed to drop that arm. I actually invited Dr. Messier out to Iowa. At the time, we didn't actually do it, but I was saying, how do you make this work? Because we're being careful. So I've worked on high intensity but low load training with things like aquatic exercise programs where we can use the viscosity of the water to progress their resistance, but a bit gentler on the joints for some people, and using blood flow restriction exercise where we use low loads, but I wouldn't call it low intensity because the signals that the muscles are getting are similar for the low load blood flow restriction studies or exercise programs to what's done with high load machine training. So I've really found that the low load is better tolerated in the studies that I've done But you can't, it's hard to argue with the results that he's gotten, and even looked at the X-ray and cartilage findings on MRI after the high load study that I've seen published.
Thank you. So Dr. Snyder-Mackler, I would like to ask you another question. So we have talked a lot about quadriceps training here and targeting the quadriceps, but what muscle groups do you really think need to be targeted with strength training? Is it only the quads, or?
It's not only the quads, but the quads get, the quads for some reason in intra-articular, they're intimately involved with intra-articular knee disease. So anybody who has an intra-articular knee injury or intra-articular knee degeneration, for some reason the quads deflate. There's some neurological connection with the quads. They seem to be disproportionately affected. So if you have to pick one muscle to go after, that's the muscle to go after. But the other part is measure and just see. There are normative data out there. If you have unilateral knee OA or unilateral arthritis, you can do limb symmetry indexes, and if they're weak, strengthen them. I would say probably the next most common next most common weak muscle is not the hamstrings, it's the hip abductors. We see this in all of our patients. They develop a Trendelenburg, so which shows that they have hip abductor weakness. It can be super subtle. So you can measure it. You can assume for sure that the quads are weak, and you can a muscle, the hip abductors only have to lose about a half a grade for patients to manifest a Trendelenburg. So you can just use that to assume that that hip abductor is weak. So I'd go after those right away. And then, and again, that's what all of the work that you guys have done you've looked at, for example, bridging exercises, which pretty much anybody can do. Great exercise for the rest of the core as well. But, I would target, again, you can target a lot of different things, but I would target quads for sure, and hip abductors and hip and knee OA.
Thank you, Lynn. Neil, you have something you'd like to add?
Yeah, certainly I agree with what Dr. Snyder-Mackler was saying about the quadriceps and the hip abductors. Hip abductors are not only abductors of the hip, but also they control the rotation of the femur, which is very important for patellofemoral osteoarthritis symptoms, patellofemoral pain, and seems to be important in lateral tibiofemoral OA as well. I do have a question about something that you said before. You said that to walk upstairs, someone needs about 60% of their quad strength, or uses about 60%. Did I hear that right?
Foot over foot, up and down stairs.
Okay. Now, if you have, let's say, a 100-kilo person who has a certain amount of quad strength, like maybe they have 180 Newton meters of torque, and then you have someone else who maybe has 100 Newton meters of torque for their maximal strength.
I'm sorry. I think you're thinking I'm talking about peak torque to body weight, and I'm not. I'm talking about if they had a normal limb, sort of 60% of what their normal limb, and I don't know what that would.
I was just thinking, for a strong person versus a weak person, wouldn't a weak person need to come closer to their maximal strength than the strong person?
Oh, yeah. If they are weak, you're absolutely right. So I'm talking about compared to a normal limb, 60% of that. So that is true.
No.
They're going to have to use a great percentage of their capacity to be able to accomplish that. And that's what we don't see, what we see in our patients. Yeah. Until they reach that threshold, they take steps one step at a time, instead of foot over foot. They just can't. They can do it by doing all kinds of other accommodations. They can use a trunk lean. They can both forward and sideways to try and accomplish that, but they're not really doing it the way they should, and that results in a whole bunch of other downstream consequences of their accommodations.
Because it sure seems like they're functionally relevant thresholds of strength, where if you come near or go below a specific threshold, then you have significant problems, and you need to compensate in a variety of ways.
Yeah, like I said, that could have downstream consequences. And the other thing is, if you are just at the threshold for a task, that might mean you could do it once, but that doesn't help us when we're taking, hundreds and hundreds and thousands of steps a day, or going up and down. You can't just, you got to do one step and wait. That isn't going to work, right?
Mm-hmm.
So now we've heard about promoting muscles that goes across the knee joint and goes across the hip joint. And I actually would like to ask you, Dr. Hunt, and you have something to say, and you can say that, but I would like to ask you to comment on also, what are the qualities of muscle function that are important and that you think we should measure? And are we actually measuring the right aspects of muscle function?
Yeah, and thanks, Eva. So I just wanted to quickly just respond to your previous question, and I think it goes back to what Arna was saying earlier. And your question was, what muscles do we target? And I would argue, and maybe rather simplistically, we target what's weak. And if, there's been a number of studies that have shown that hip abduction and adduction strengthening works. And there's a number of studies that show knee flexors and knee extensor strengthening works. What they haven't really shown, though, is, are the people that are going into that, do they actually need it? Are they actually presenting at baseline with weak hip abductors or weak quadriceps and whatnot? And so I think Arna was right, where it would be great if we could go in and say, here's the bevy of potential opportunities. Let's measure your hip muscles. Let's measure your quads, your hamstrings. I would even argue measure your ankle plantar flexors. I don't think they get a lot of attention either. And really target the training to what is weak. And as we showed earlier, weakness is certainly more important than strengthness, for lack of a better term. And so, I think really it goes back to, what does the individual need? And so to your second question about, are we measuring the right things? Again, I think it comes back to what is important at that given time. Is radiological findings, are they important? And we all know that it's very difficult to find any real change with any treatment, exercise or strengthening included, in anything, say, less than 6 or 12 months. So are we looking? Certainly pain is important, certainly function is important. Dr. Messier had a really great paper recently where they looked at some of the muscle qualities, rather than simply looking at strength or looking at cross-sectional area, looking at things like fiber types. So I think there's a lot of things that we can measure that just really haven't received a lot of attention, and I think we'll be very surprised in terms of what we can find, just because we haven't looked in those areas yet.
Thank you. Dr. Messier, would you like to add to that? What aspects of muscle function do you think we should address in studies?
I can tell you from the patient's perspective, they like to have a whole body routine. I think just isolating one muscle group is going to get old really quickly. So even if that's not your focus, I would do an entire, at least lower body. We did upper body as well and core. And I think they like that. The older adults like that. But certainly we focus on the knee, right? But we do everything all the way up and down the body. Does that answer your question? I like what Michael talked about as well before about neuromuscular training. We're doing more and more of that now. I think that may be a better answer than just strength training by itself.
Thank you, Arna. I know that you're a big fan of both strength training and neuromuscular exercise. Would you like to comment on that?
Yes, we usually, as clinicians, we start out with neuromuscular exercises because we also have a feeling from the clinical point of view that they are much better tolerated in the beginning, and they get used to the different and learn the different exercises, and then we gradually progress into more high strength training, but progression over time. So yes, we usually do a lot of neuromuscular exercises. I think it's really important so the patients feel safe with the exercises. Those patients that you recognize that are fearful, they need to be confident in you. If you start out with high intensity exercises and they get a lot of pain, they won't adhere to those exercises. At least that's what I think, also from a clinical point of view. So yes, neuromuscular exercises, that's a very good start, but make sure you progress the exercises. So I also think it's, as you, Michael, said, that we also need to look into what the patients need based on their specific dysfunctions, but also what they like to do, what they adhere to. Because if we are going to succeed with exercises, we need to make sure that the patients adhere to the exercises. And if the patients don't like the exercises, I don't think they will continue for 18 months. But
Ewa, can I make one more comment?
Absolutely.
So, we've looked over the years, a lot of years, more years than I'd like to admit, that we've looked at all types of exercises. And I mean, I'm getting to the point now where I'm thinking it doesn't really matter what you do, exercise-wise. You're going to get, as far as pain goes, you're going to get the same reduction in pain, which is somewhere between 20 and 30%. If you're lucky, you get a little bit more than 30. It doesn't really matter what type of exercise you do. You're going to get the same result.
So let me interject also, because I'm getting questions from the chat rooms here that, and there's a nice way to follow on what Steve just said. So Martin England and others, Yehu Wang, asked about, Steve, a little bit what you just said, and I'll open it to both Steve and others. How much of the improvement in pain observed in exercise trials, Steve and others, is explained by contextual response, a placebo response, regression to the mean, for example? And in the recent trial whose data we haven't seen but have seen here, but have seen at ACR, the difference between the exercise groups and the non-exercise groups was nil. They all improved. Is a lot of the exercise trial improvement that we're seeing due to contextual effects or placebo response plus a regression to the mean phenomenon?
Well, David, once again, I'm a little uncomfortable talking about results of a study that I'm published.
I think we can talk about this in more general terms.
Yeah,
and I would like all the panel members to give their opinion on this. And I suggest we do it in more general terms. And the problem here is, of course, that it's very difficult to devise a true placebo control group in exercise trials. So what are your opinions in general about this question? Steve, would you like to start?
Yeah, I mean, I think paying attention to people is a big deal. I think a lot of what we see in the exercise group is just paying attention to them. When we pay a lot of attention to the control group, more than we have in previous studies, then I think we got what we got in this study, and that is the control group did really well. And the other thing that I would like to say too is I think one of the most impactful presentations that I ever heard was by Peter Uni, when he talked about small sample clinical trials. And when you have less than 100 subjects per group, the effect sizes are much larger than when you have over 100 per group. And also when you increase the duration, the longer the duration, the better the control group does as well. And I think those two things, maybe impacted our study. We had well over 100 per group in our study. 86% of them finished the study out of 377. And we went for 18 months, which is a long time. And we paid a lot of attention to the control group. We had one interventionist that was just focused on the control group. Yeah. And so maybe that's part of it too. And Martin and I have had lots of discussions on this.
If we go back to discussing this in more general terms again, not a specific trial, but in general, we all know that self-reported outcomes, pain in particular, is more susceptible to context or placebo effects compared to objective outcomes. And we sometimes also use objective outcomes in these trials. It's not only self-reported pain, but it also different measures of muscle strength, for example. So I wonder if there's anyone in the panel who would like to comment on this, and if we see the same improvements in muscle or more objective measures as we do in the self-reported measures, or what is your opinion about this? Anyone in the panel who would like to comment?
Can I jump in real quick on this? We have some really, really good data that we've published on patients before and after total knee arthroplasty. And we have patient self-report on instruments that have IRT analysis done on them, so you can look at each of the questions. And then we have, so for example, there are questions about how are you doing going up and down stairs, walking, swelling, pain, strength, range of motion. We ask them those questions pre-op, and we measure all of those things, including with 6-minute walks and stair climbing and all of those things. And then we see them their first, 4 weeks after the total knee. And in every single case, their actual performance is worse. Their range of motion is down, their strength is down significantly. They have more swelling, they walk slower, they are worse on a tug, they're worse going up and down stairs. In every case except the swelling question, which is they're looking at it, they say they're better. And they're not, they are significantly worse, but they say they're better. And our assumption about that is pain trumps everything. And so if their pain's better, they say they're better on all these things. And objectively, they are incredibly worse.
Or could it be the fact that they've had a very expensive intervention?
No, it could be, but it also could be that their pain's better. They're 4 weeks after their total knee, they're 4 to 6 weeks, they're better. Their pain is gone. And that's but I mean, David, you guys have spent a ton of time studying like residual pain issues, but also the function. So patient satisfaction and happiness as measured on a lot of these patient-reported outcome measures does not necessarily translate to their function or how they're going to continue to function. I mean, part of the reason that we see that patients, pre and post-op total knee is their function a year later is about what it was pre-op, but they don't have pain, right? Is that okay? I don't know. Again, if happiness is the key, then fine. But I would like their physical performance, their functional performance measures to be better. So it depends what your outcomes are. That's why I'm uncomfortable discussing Steve's paper, because I have no idea what you measured.
No, of course
right?
not. We should not do that. Anyone else in the panel who would like to comment on context factors and placebo effect in exercise trials? Neil?
Well, I don't know if I would be directly addressing that, but there are a few comments that I would like to address. So Dr. Messier mentioned the kind of broad comment, it doesn't matter what exercise you do, people feel better. And there's certainly, I can see where that comes from, but it also depends on what you're measuring. As Dr. Snyder-Mackler was saying, what patients report on PROs is different than what we see on physical performance measures. And like many of you, I include both, like a KOOS or a WOMAC, and also physical performance measures in my studies. And what I find is that it does matter which exercise you do if you're looking at physical performance. So when I have people just like exercising seated on a machine doing knee extension, it doesn't necessarily improve their walk time or their chair time or their stair climb. But if I have them doing something like a leg press in the same duration of sessions over the same number of weeks, the leg press does seem to help. And so I think there are more functionally relevant, or the NEMEX, the neuromuscular exercise that has been done in many of your studies, also seems functionally relevant. So if we look at performance, I think it matters which exercise you do. If you just look at, is the patient happy? Do they report less pain on a PRO? It doesn't seem to matter as much whether they do aerobic exercise, strengthening. So I think it depends on our goal.
Thank you, Neil. Arna, would you like to comment?
Yes, and pain is such a multifactorial phenomenon. And that's very, very different from just measuring changes in muscle strength. And we all know that if we add information to the patients as they do their exercises about reducing their fear of movement, they get confident in their body moving and different exercises that they do. They learn to cope a lot better with the daily life. They learn to know that it's not, if you have some pain, it's okay. All these components are so important when you look at the patient-reported outcomes, including patient-reported outcomes of pain. So muscle strength is just one factor. And as Lynn said, as we have seen in many studies, sometimes it doesn't seem that they are improving in physical function, but there is one very important thing. We also know that if you have really lousy physical function, we know that is also, at least in post-traumatic knee osteoarthritis, as a big, big predictor of worse outcomes long-term. So it is very important also to focus on the functional performance measures.
Michael, would you like to comment on this?
Yeah, and I think, you know, what we're hearing is kind of all kind of saying the same thing. And really what it comes down to is what are the goals of the treatments? And I would argue that the goal is to improve health. And I use that term in a relatively broad sense of the word, whether we're talking about joint health, whether we're talking about muscle health, whether we're talking about psychological or mental health. I think, you know, those are all important things. And, you know, to Dr. England's question, yes, I mean, most treatments that we've studied from a muscle perspective and exercise perspective work. Now, does it really matter whether it's a placebo effect or not? You know, some would argue no. But I think what Dr. Snyder-Mackler is talking about for sure is that there are other factors that are important. And my concern would be is if we only focus on one of those multitude of factors, then, you know, we might be losing what are some of the important aspects of a trial. So, you know, I'm thinking of the IDEA trial, for example, the intensive diet and exercise trial. You know, pain, of course, is important, but they also measured self-efficacy. They measured metabolic factors, and, you know, those are certainly important things. And a given intervention might have different effects on some of those different outcomes. So, you know, I think, again, it goes back to what is important, what we perceive as important, but also more importantly, what the patient perceives as important.
I think we're also looking at two different groups here too, right? The traumatic OA is much different than idiopathic OA. At least I think so.
But across the board, Steve, and I think everybody would agree, and this is something that I think we really wanted to address here. I think, David, with your choice of this topic, is one thing we can say is this isn't dangerous for people to be doing. Like patients should not be avoiding strengthening exercise. They just shouldn't be avoiding it. It's not going to hurt them. In fact, it is very, very likely to help them. And
it does no harm.
Yeah. Well, and it may be good. In fact,
I'm talking about structurally. Structurally, it does.
Structurally, it's not going to do any harm. And that is the part that I think we really want to get across to all the practitioners here and any of the patients who are stepping in. Don't be afraid to exercise. Again,
right. And Lynn, you would say that goes for both the idiopathic and the
absolutely.
PTO.
We don't want our young athletes with knee injury to not exercise. They will start a cascade that is even more detrimental. So get some advice, go to a professional, figure out a starting point, which both Steve and Arna brought up. Like, you don't just start at the super high point. Get in there and begin under some supervision and then progress. But don't become a couch potato. That's really bad for all the way around.
So let's switch gear here. And here, I would like some advice from you on the panel to clinicians and to researchers in the audience. How should we measure muscle function in the clinic and in research? Michael, would you like to start?
I think the easy answer to that is measure it to the best of your ability and to what resources you have. And I think, you know, I hear a lot of people talking about, you need to measure isometric strength, you need to do that. But, you know, as you've shown, even, and certainly Lynn, as you've shown, something as simple as a single leg hop or something as simple as a chair stand test does provide a very good measure of overall muscle function that can be measured in a clinic, but it can also be measured at home. And so, I always adhere to what's sexier isn't necessarily always better. So I would argue that what the worst thing to measure is nothing. And
Right.
so,
Thank you.
Maybe I'll just leave it there.
Would you like to add to that?
Oh, me? I'm going to say measure. I am all about measuring.
Are
Measure.
you, Neil?
Oh, okay. I thought you called on me.
Sorry.
Yeah, so I agree with what Dr. Hunt said. In clinic, we want to measure what we can. If you want to know, someone's plantar flexor strength, you can have them do single leg heel pumps to see how many they can do. Can they do 20 or can they do less than 20? That's functionally relevant. Or you could have them do the single leg stand or single leg squats, as Dr. Roos has described in her studies and others. So I have people do quarter squats sometimes if they're elderly, don't have much strength, or deeper squats if they're more. So I do what's possible to do for the functionally relevant, usually quads, hip abductors, and plantar flexors.
So, Arna, would you like to add? And I also wonder, would this be acceptable in a research study? Are these measures reliable enough, etc.? Add your experience.
I would just also say that the most important thing is that we measure. And I think that's one of the big things that should be out there for all clinicians. We should be much better in measuring strength and function. I don't know how it is in each country, but at least Norwegian physical therapists should be better in measuring, because that's the only way to continue within this area. But of course, for the research purposes, I believe, and I also really liked the talks today, that really shows how complex the muscle organ is, meaning that we need to measure more than one thing. We need probably to measure more than peak torque to be able to grasp the different components of muscle function, quality, rate of force development, peak torque, to find out how can we transfer these to clinical relevant functional tests.
So let me
Would you like
interrupt.
to? No, you have to wait, David. You will get the word very soon. Steve, would you like to add to this?
Somebody told me, a physiologist told me 30-something years ago, he said, if you're strong, you're strong. If you're weak, you're weak. It doesn't really matter what test you do. It's the people who are strong are going to come out good on just about any test versus others. And I think there's some truth for that. Obviously, it's not 100%, but what we try to do is something that is reproducible from a research standpoint, that someone could replicate our study, and we don't do some fancy strength test that no one else has. They'd have to build something, that kind of thing. So we try to do something that is reproducible, that we can do from study to study, and other people can do as well.
Thank you. Lynn?
I have a little bit of a pet peeve about studies that purport to be doing strengthening interventions, and then they measure other things as outcomes, and never actually demonstrate that their strengthening intervention actually increased muscle strength. So as a researcher, if you purport that you're doing a strengthening intervention, you must do something to show that your intervention actually was a strengthening intervention. If it did not increase the muscle strength, then you were doing something else. And it may in fact have the same effect as the other group that you were doing, but you must test, individual, one muscle at a time, muscle strength, to make sure that your intervention actually did what you purported it to do. Otherwise, you can't say that you were doing a strengthening intervention. So, this happens not just, believe me, not just in OA. It happens across the board. So,
Thank you.
you gotta measure it. If
Thank you, Lynn.
say that's what you're doing.
So
I think we'll have to end these advices here, and I will very soon hand over to David, who may have some follow-up questions. But before we do that, importantly, it's time for some testing. So we're all going to do the chair stance test, the 30 seconds chair stance test. So I will count you in, and if you in a safe way can stand up and sit down again and count how many you do during 30 seconds. You have to keep count yourself, of course, because I can't see you. I will count you in. So please adjust your chairs so you can do this safely. Ready, set, go. Steve, I can see you. You're not contributing. Come on. 10 seconds to go. Come on. It's only 10 more seconds. Can you do 1 a second? David, you're doing excellent. Perfect. I think you need it. Very good. Stop. So anyone who could do more than 30, raise your hand. Neil, you could do more than 30. I can't see everyone. But everyone who could do more than 30, they could do more than the best OA patient that we have in the GLAD database that holds data from about 30,000 patients who have done this test. Anyone who did less than 10, more than Steve, who didn't do any, then you have an increased risk of falling, and you really have to work on your muscle function. So with that, I would like to hand over to David.
Well,
and here, if you have,
sorry, Eva. There's a lot of good questions and that move us to different topics of discussion that are in the chat room. So let me ask, and I guess I would ask for brief responses because we're, make it pithy and informative. One question is how to tailor exercise. I think we had some of that discussion already, and how to motivate patients to adhere. And to strengthening on other exercise. It isn't technically about a topic of interest, but it's certainly a terribly important topic. And I wonder if there could be some comments about that. How do you get people that you've trained, okay, to do a strengthening intervention to continue to do it and adhere to this at home or in a classroom? Neil?
Well, what we do know is that they have to like it. If they don't like it, they don't continue it. Other things that we know is if it's an organized exercise program, they're more likely to do it than something that they just have to do alone. And having social support also seems to be associated with better adherence. We haven't found, and also in your recent study with Dr. Baker, found that telephone encouragement doesn't seem to always help with this.
Other comments?
I would like to add something, because a subgroup of people, they love the technology, they love to use the Fitbit, they love to show their results. For some OA people, that could also really increase their adherence.
Okay.
But I don't think the patients are any different from we are. All of us who adherence to an exercise program, regardless of what it is, whether it's therapeutic or, it's always better if you do it in a group. It's always better if you promise somebody you're going to meet them to do it. If you, all of those things that Neil talked about are really similar to all of us who fall off the wagon of exercising. So we have to, the more fun it is, the more you commit to somebody else, the more likely, most of us aren't that self-motivated to just, that's why Peloton sold out during quarantine, right? Because you were in a group doing this. And also to some degree, what my Arna said, competing with somebody else, like you do sometimes with Fitbits on social media.
Other comments or thoughts? So
I would like to have something. Can I do that, David?
Pardon me?
Although I'm not on the panel.
Yeah, absolutely.
I would say that providing exercise therapy combined with patient education, I would think is key, because patients need to learn about, for one thing, that exercise is not harmful for the structures of the knee. They need to learn that they will get pain flares when they start. They will decrease with time. They need to learn all these things about osteoarthritis and its nature to feel safe, because it can create a lot of anxiety if you have painful joints and we tell people to exercise. And most people, they require someone to hold their hand when they start. And some of them need to hold a hand also when they're continuing. So I would say that exercise therapy for osteoarthritis is actually a highly specialized thing, and it requires a lot of efforts. Some people can absolutely continue and do something with their peers, and some we cannot change, but some definitely need continued support to be able to exercise. It needs to be individualized there as well.
Okay, what is the role for motivational interviewing and text messaging or smartphones in getting adherence to be improved?
I think there has been lots of trials on that.
Mm-hmm.
And I'm sure that someone has done a systematic review on that recently. Maybe you should answer.
I don't know that there's, but if you're in the chat room and you want to inform us, that'd be great, and we can unmute you. That'd be fine. Let me ask a different question, because Jackie Whitaker had a question that was replicated or affirmed by others. And it goes back to neuromuscular function, muscles that do too much and muscles that do too little. Okay, do we need to proceed the intervention by determining whether we need to downtrain or uptrain muscles and then allocate to an appropriate intervention? Anyone have any thoughts about that? I mean, most of this has been about uptraining muscles. And the question is there a role for a different approach in some people?
I don't necessarily think about it as downtraining muscles, like we want to inject them with Botox to make them weaker, but we do want to establish appropriate balance. So, I mean, hamstrings and quadriceps, they need to work in concert. They don't need to, if you have too much hamstring strength compared to the amount of quad strength you have, I wouldn't necessarily detrain the hamstrings as much as we would need to increase quad strength so that you have balance. Something that you'd mentioned earlier were our studies in most, where we found that in general, if you look at just the statistical significance, you know, in women, we found associations between quadriceps strength and various outcomes, radiographic OA, symptomatic OA, progression of OA. And as you mentioned, we didn't see that in men. I don't know that that's strictly, I mean, it's strictly true from a statistical standpoint, but the point estimates for men and women were almost identical in most of those studies, but there was more variability in men so that the confidence limits for our odds ratios included 1. So it may be that in men, if they're too strong or if they're too weak, there was an association. And so that variability caused us to find that it's important in women, but not in men. But if we had looked at it not from a linear perspective, but from a nonlinear, we may have had slightly different conclusions to those.
Okay. Let me ask about another issue that I know has arisen in our group in discussions. Abnormal pain processing, like exercise-induced hypoalgesia and pain sensitization, how do they affect recommendations related to strength training? I don't know if any of you have sort of begun to address this concern. Are there some people who have different responses to exercise with respect to algesia responses?
I want to say there are studies that we really are considering when we talk about this in journal clubs in our clinic, which is a very research-based clinic. But it always, when we come back to these discussions with the clinicians and the residents, the PT residents, what always seems to come up is, what do we do about it? How does one address this? And I'm at a loss.
Let me just follow up from Jackie Whitaker, and I'm happy to unmute her if I can find her. is that by down training, she was really referring to problems with co-contraction and whether you want to try to do anything to eliminate or minimize co-contraction. Is that part of the initial evaluation that you folks, some of you talked about? Is there a need to understand whether there's a lot of potentially dangerous co-contraction going on that might need to be modified or down trained, as it were?
Well, David, you know, some co-contraction is good, right? Because it helps to stabilize the knee, all right? So you don't want to eliminate co-contraction totally, but if you have too much, then of course the muscles are where most of the force on the load on the knee is coming from, right?
Right.
In addition to just the body weight. So you want to try to minimize that. We found that when people lose a lot of weight, co-contraction goes down. Quadricep force goes up, hamstring force goes down, just with the decrease in the load. So I think with training by itself, I think that kind of, as they get more used to doing the exercise, or if there's some weight loss with it, that I think that kind of takes care of itself. I don't think we have to interfere with the process that takes place as people get more fit.
I think that in our PTOA population, when we see co-contraction early, we think it's a bad thing. And we have developed strategies like perturbation training for trying to break up that co-contraction. So I think it's different in those.
Yeah, and to follow up on that, I agree with Neil. I wouldn't call it detraining. I would call it that we address the co-contraction. You can measure this, or you can just at least qualitatively evaluate it in the clinic while you see patients hopping during the landing phase. You see this stiffening of the knee, and these are also things you address in the clinic. But I wouldn't call it detraining. I would use perturbation training, as Lynn said, because we know that helps.
Okay. I think the one thing I would just add, and Steve, you kind of alluded to it, was it depends on what your thoughts are regarding the increased compression that you would get from a co-contraction versus the increased stability. And I would argue that for someone who's got a relatively stable joint, I think co-contraction is bad. For someone who's got a very unstable joint, I think as you said, some level of co-contraction is probably a good thing to maintain that. And so to say co-contraction is good or bad across the spectrum is probably not appropriate.
I unmuted, I think, Tuhina Nyoji, who can speak a little bit to pain processing and exercise-induced hypoalgesia. Tuhina, are you on?
Yes, thank you. I really think that's a very pertinent question, since exercise and strength training is first line, but if someone has abnormal response and they don't get, or they have impaired exercise-induced hypoalgesia, it would be ideal to address it. And Lynn, to your point, the question is, well, what do we do about it? And so I do think that's an important clinical question about strategy, because obviously if someone has impaired exercise-induced hypoalgesia, sending them off for strength training and exercise first may set them up for failure. And so I think an active area of research needs to be in phenotyping these individuals and then figuring out what to do. We have some studies in the field where we're assessing this. And I think it speaks to the broader issue of needing to better understand these altered nociceptive signaling pathways and functioning, and how to address them. Another issue that we've noted is that pain sensitization is associated with more muscle co-contraction. So this isn't only, pain sensitization isn't only about the pain experience, but may have effector implications as well. And so Lynn, I think the clinical implication for what to do about these individuals is something that we're studying right now, about how to alter that response to improve it so that they can have the expected exercise-induced hypoalgesia.
So let me come back to an issue that's been sort of back and forth. On the one hand, there's been discussion about individualizing treatments, and Tuhin has just got into one subset that's really individualized. We talked about co-contraction and its potential risks or benefits, and that entails individualizing. And we talked about people who are weak or strong and wondering whether we ought to be focusing our strength interventions, especially on those who are weak, and perhaps not. In future studies and in clinical practice, and there was also discussion of sort of what data do we collect in research and in clinical practice. How should we deal with this individualization set of issues in proceeding in future studies? What are the big ones that we need to address? What should we be consistently measuring? And I think, as Lynn said, we need to measure to paraphrase our Speaker of the House. What would we be measuring? And should we be embarking on trials that test out particular subgroups of people who have particular weakness problems and or co-contraction problems that aren't necessarily a one-size-fits-all approach to what we do? I don't know who to call on. Are there people that want to speculate here? Eva?
Yes, I would like to add, I think this is a really good question. And one way of approaching it would be to have goal-based programs. Because then you would take into account that people start at different levels and they may need different doses of exercise to reach a similar goal. That is one way of doing it. And that is often how it's done following knee injuries, for example, that you have certain criteria you should meet, but it may take different time for patients to reach those goals, and they may need to take different routes to get there. I think that's a very pragmatic type of study that I personally would like to see more of in knee osteoarthritis.
Well, Eva, that you mentioned the word pragmatic, and I think our clinical trials are heading in that direction, and just by the word, it suggests that there's less and less interaction with the participants. And so I think one of the problems with
that's not what I mean. So then you better improve my English and come up with a better word for it.
Okay. Well, I guess my point is that as we move towards the larger trials, more subjects, less interaction with the participant, that trying to individualize a program would be extremely difficult, I think.
But I would like to measure and make sure that they meet their goals. They could be intermediate goals and there could be final goals, but measure to make sure they get.
Well, the pragmatic trial by definition, by 100%, would be that you don't measure them until the end. Okay.
Tell me what
you measure them at the beginning, and then you let them go, and then you measure them at the end, and you do very little in between. And so if indeed we're going in that direction, so we can take these interventions into the community, then specializing or individualizing is going to be, I didn't say it's going to be impossible. It would be more difficult, that's all.
Other comments or thoughts?
Yeah, but I think those kind of studies would be very, very important. That's if we really believe that our research should be implemented in the clinic, that's where the clinic as a clinician, I would love those kind of studies to have more information of how you tailored the specific interventions to each specific patients. But we have to come up with a better word, Eva. I thought it also was called pragmatic studies, but I understand that's the wrong word.
I think Steve's talking about pragmatic trials the way Pecori defined them.
Right.
Well,
people,
it would be a mechanistic study. It would be a mechanistic study.
But let's talk about, I think what David was asking, I'm not sure, maybe you were asking about research, David, but I think you might have also been talking about implementation. So Eva, we could talk about the things that Arna and I are talking about a little bit in terms of each individual tailoring things for each patient who comes into our clinic and measuring them and seeing where their deficits are and hitting those things. And then going to your GLAD study or your GLAD program or similar very large scale programs where you decide that there are interventions that are so good that we should generalize them to everybody.
But actually, we do exactly the same thing there. There is a first introductory session where the therapists decide on what level the patient should start. So it is individualized, and then they progress it with time.
So I think it's sort of depends on where we're coming at this from. I mean, I think we need to be very aggressive and very individualized when someone has a new intra-articular knee injury. I think we need to start them right then, letting them know that they are on the train for knee OA and that we know there are things that they shouldn't do, which is number one, stop exercising.
So David, we are approaching 8 p.m. my time, and I guess it's 2 p.m. your time. So it's time for dinner. Would you like to take over from here and then?
Sure. I think I would thank the panel. There's a lot of very valuable insights and suggestions and that you all raised. And it was a lovely panel in that you worked together, but also had different views of things, which was very nice because I think it gave the audience a sense of the range of potential opinions and approaches to this set of problems. Hopefully the audience, which can hopefully get back to us, found this educational and helpful in their own research and clinical practice. And we hope future fora sponsored by the Arthritis Foundation will be as good as Lynn said at the beginning of this. It's all going to be downhill from here, but I hope it's not. So thank you all for attending, and thanks to the panel, which we'd love to give applause to, but it's sort of hard, for participating in ways that were very helpful and informative.